I was showing a few people my notes before we started today. I'd given my experience with visual issues denial. The last time I spoke, 10 minutes in, I had to put my glasses on because I couldn't see anything. So I wrote at the top of my own notes, "Put your specs on." And I was showing that to a few, I'll call them friends, and they said, "Well, you can't actually read it, it's the smallest font, so you won't know what's there until you put them on." So welcome to Advancing Together, Building Emergency and Critical Care Capacity across the region. We firstly acknowledge the traditional owners of Naarm, the Wurundjeri Woi-wurrung people of the Kulin Nation. We pay our respects to their elders, past and present, and to elders of all First Nations communities that are with us at the World Health Summit today and over the 3-day period. Hi everyone, this is exciting, at least for me and hopefully for you, because long have we, emergency and critical care, bemoaned what we thought was the chronic invisibility of emergency care and critical care. This is not the first time we have fostered and enjoyed regional partnerships. It's not the first time we have fostered and enjoyed organisational partnerships. It's not the first time we have fostered and enjoyed, which can sound like endured if you don't get it right, enjoyed interdepartmental, craft group and interdisciplinary partnerships. There have been long, healthy and enduring partnerships along each of these lines for some time. But now, and including with programs such as the Regional Emergency and Critical Care System Strengthening Initiative, now we are scaling up local, regional, organisational, interdepartmental, intercraft, interdisciplinary partnerships, everything, everywhere, all at once. Now I wrote that and I thought, I think that's a film, which I hadn't seen. I thought I'd better just check if the film matches the theme and is appropriate. And I just, in Google, I went everything, everywhere, all at once, synopsis. It said, when an interdimensional rupture unravels reality, an unlikely hero must channel her newfound powers to fight bizarre and bewildering dangers from the multiverse as the fate of the world hangs in the balance. For that I read emergency and critical care. Meanwhile, back on Earth, the World Health Assembly Resolution 76.2, which will appear shortly. Cool. That was excited. Integrated acute care, this is about. Perhaps somewhat on the back of lessons actually learnt during a viral pandemic, amongst all the tragedies. You can see the date there, that's pretty current. The World Health Assembly Resolution 76.2 has taken what we already know and we already do and legitimised our collaborative partnerships, all of them with a birth certificate, if you like, a passport, a marriage certificate between emergency and critical care. And an incarnation of this resolution is, for example, one incarnation is the Regional Emergency and Critical Care System Strengthening Initiative that we'll hear more about later. So this is very exciting. With great privilege comes great responsibility. No more whinging. It's been recognised as important. Now we've got some things to do. So this session that I welcome you to is divided into 3 sections. Part 1, emergency and critical care across the globe. Part 2, collaborative development case studies. And Part 3, strengthening regional acute care capacity through partnerships. And to start is me, just talking briefly to global emergency care. I'm Gerard O'Reilly. I'm an emergency physician. I work at the Alfred in Melbourne with an appointment at Monash University, and it's great to be here. Global emergency care. A decade ago, as I have implied, for the collaborative of emergency and critical care, this essential piece, emergency care, in terms of the health system, was missing. Now I can comfortably summarise some key overarching concepts in 3 slides using freely accessible WHO resources. These and the content of all the tools and resources that have been developed by WHO have been informed by many or all of you in the room and your many years of working in this space. So for global emergency care, these 3 slides help paint the picture, the story, the journey so far. Before there was a 2023 resolution about integration, there was one about emergency care and about universal access to emergency care. This was huge, as I said. After a lot of work in this space by a lot of people, WHO was able to bring this and put it on the agenda of countries globally. And parallel to that, required some understanding of what is this thing, emergency care? What is an emergency care system? So putting all the pieces together, and if you like, all the functions of an emergency care system, because it's about functions rather than one specific place, this graphic was created and still maintains its relevance now. And for each of those functions, and I should refer especially to the small print in the top left-hand corner that you can't see, which really is paying respects to the words of Ola Kobasinji from Uganda, who's been working in this space, and particularly in the injury space, for a very, very long time. All around the world, acutely ill and injured people seek care every day. Frontline providers manage children and adults with injuries and infections and heart attacks and strokes, asthma and acute complications of pregnancy. An integrated approach to early recognition and management saves lives. This visual summary that you see here illustrates the essential functions of a responsive emergency care system and the key human resources, equipment and information technologies needed to execute them. And thirdly, the resources that have filled the vacuum in the last 10 years. Again, informed by many of you in this room and many of the places that you're representing, that you've travelled from, have been involved, so that these are globally relevant, not just relevant to high-income countries, but resources that are globally relevant. They include emergency care system assessment tools, emergency unit assessment tools, clinical checklists, trauma care checklists you'll know about, some of you, triage tool, the basic emergency care course, a clinical registry for emergency care, clinical forms that go with that, collecting that data for the clinical registry, but also informed care. But there's still some work to be done. Coming down the pipeline, quality improvement resources and tools, and a number of other things. Not just in emergency care, but across critical care, operative care, all components of integrated acute care. That's the vignette on global emergency care. And now I'd like to hand over to my partner in this marriage, one of them, Dr. Steve McLaughlin. Steve is Program Director, ICU Alfred Health, Technical Officer at the WHO Health Emergencies Program, recently returned from the WHO. Thank you very much, Steve. We'll talk to global critical care.
Thanks. Thanks, everyone. Jared's always a hard act to follow, as you can imagine. So one thing that's really interesting, I'm going to talk a little bit about critical care today, is that we don't have the websites that Jared just showed for emergency medicine. So there is a lack of recognition about critical care. Obviously, the pandemic has brought that to light. I guess speaking from myself and many of my colleagues in the critical care world, it's an interesting concept, critical care. It's an expensive part of the healthcare system. But there's 3 things I'd like you to remember in regard to that. So the first thing is, if you are critically ill, do you think you are deserving of care anywhere in the world? Are you capable of holding a parallel thought? So can we do public health, preventative medicine and critical care? And I would argue that we could. It's not about one or the other. And often we get caught up in a one or the other. We can't afford to do everything. And the third thing is that at the moment we are getting caught up, and this is where I think this program is really excited in, and it was brought up yesterday in many of the talks, in siloed thinking. So we don't know exactly, but we know most of the critical care patients in the world are not in intensive care environments. They're in hospitals, presumably, or sometimes not even in hospital. But we know that the amount of resources, the amount of adequate care is very small, and we know that the care is not provided in the right environment. So what we'd like to do with RECSI is try and sort of shine a light on critical care and also demonstrate that we are capable, as we haven't always been in the past, of working with partners and colleagues and the emergency department in particular to improve the care of critically ill patients. I didn't use a quote from a movie. I should have now, although I did like the use of the Spider-Man quote. I noticed that in the middle of that talk, Jared. But because I'm not very clever, I thought I would use some comments from some clever people from articles recently that you can have a read while I'm here. So it is an under-prioritised area. There is almost no country that's providing adequate resources or training at the moment. And what is really clear is the countries that are most fragile with the worst resources have the worst outcomes and the highest burden of disease. And really trying to silo one of these areas off. And if I was to be critical of the emergency one, which the guys that know that I work with emergency departments regularly, I would say that's the error of the emergency WHO resolutions, is that they stop at the person gets into emergency and into hospital, and then there's a magical box that fixes them after that. So we're trying to sort of say, well, that's great. Emergency is obviously great. Pre-hospital stuff is great. Operative care is great. But there are continuums in between that we really need to focus on as well. Like I said, it's very hard to actually come up with numbers about how much critical care is provided in the world. It's probably impossible, and any graph would just be making it up. But if you use sort of research during COVID as sort of a marker for adequacy of critical care provision, this is probably as good as you can do. This was some Australian people did this. And this is the amount of patients. It's one of those clever graphs where you can see that the bigger the circle, the more people were included in studies with COVID-19. So you can see, obviously, relating to income where research was done on patients. Now, these are not all critically ill, but COVID-19 patients in hospital, you could argue, are on, obviously, that continuum. And you can see as you go upper middle, lower middle, it tails off to nothing. There's another study that shows, that also looks at other biases that came up in critical care provision, which basically says if you make that gender specific, it becomes even more prone. So basically, if you're me, between the ages of 40 and 60 and white male, you're in research. Otherwise, you weren't around the world. And that's the same for critical care access and provision. And then just to finish, and just quickly, because I want to get on to some of the far more interesting speakers than me, is just to sort of expand on what Jared said. There was a 2019 resolution in WHO, but there is some other ones that are also relevant as well. So the access to medical oxygen. We've got some colleagues here from PNG and other places. We know many countries in the world ran out of oxygen or didn't have provision of oxygen, which makes it sort of remarkable when you think about it. So there's obviously a huge amount of work going on to increase the access to medical oxygen around the world, which obviously relates to emergency and critical care as well. I'll put the research one up there because I think it is really important. Like, we know that people with access to research, there's quite a lot of evidence now, sort of to use the same word twice, that if you have access to research in whatever environment you do, you tend to get better clinical outcomes. It's sort of irrelevant of what the research is, to be honest, probably because it adds governance, communication. Don't tell that to researchers. Sorry, there's some very eminent professors in the room. But research overall is important because it does improve outcomes and it does increase governance and ability for systems to deliver care. And then, as Jared said, we've got the resolution just from last year, integrated emergency critical care and operative care. And I think I would argue that the most exciting thing about that is the continuum of care, that it crosses over all the specialties. The problem we have is that emergency has that nice slide that Jared had. It's very good. I like the slide. And operative care have a lot of stuff too. I know there's some surgical colleagues here that have checklists and other things that were all brought in 20 years ago. The WHO webpage about critical care refers to the emergency page because there isn't anything yet about critical care, despite the pandemic coming through. So that was part of my time at WHO, is really trying to think through how we deliver this. And the big thing for me that I realised was collaborate across other specialties, and also to remember that critical care rather than intensive care is probably the key thing, because we know it happens outside of intensive cares at the moment. And so I want everyone to think today about how we provide critical care in all the environments that we're talking about with RECSI. Thanks very much.
Thanks very much, Steve. I'd like to now hand over to Dr. Arabella Colliwan. It's a great pleasure to have Arabella back in Australia, and she is an emergency physician and Director of Clinical Systems, St John's Ambulance in Papua New Guinea. And Arabella will speak to emergency and critical care provision across the Pacific region, insights from PNG.
Good morning, everybody. Thank you very much for the conveners of this meeting for giving me the opportunity to speak about emergency care and just sharing a perspective from Papua New Guinea. It's really exciting to be in a room of so many people that are invested in making sure that our systems of emergency and critical care are getting better, especially in the way that we're delivering these essential services across the region. In terms of what's happening in PNG, I'll only speak this morning about the emergency care experience because that's the field in which I practice, but I understand that critical care is experiencing somewhat of a parallel journey to what we've been on over the last 20 years. In the last 20 years, we've seen a rapid growth in the development of emergency care in Papua New Guinea. We began our specialist training in the early 2000s, giving us the capability to train emergency physicians to practice in our local communities and deliver this essential care. In the beginning, there were very few people that were practicing in the space, and what we see today in terms of emergency care has really been built upon the efforts of our pioneers, where very few people had the ability to be advocates, have the ability to build capacity, build systems, function as subject matter experts, and also advise national bodies on the way that this particular field of clinical medicine was being delivered. Because there were so many competing priorities and a lot of pressure being put on quite a few individuals, what the result was what we now see as one of the challenges, a patchwork of emergency care systems, resources, protocols, and really a lot of inconsistency in the way that we deliver emergency care. Over the last 20 years, while there has been increased buy-in, and we're at the point now where we have 14 out of 22 provinces in PNG with emergency care systems that are being led by locally trained specialists. This patchwork of systems has perpetuated because people have gone into places where a system didn't exist and needed to really build things from scratch. So with increasing recognition of the importance of emergency care in achieving universal health coverage, we're now at a juncture where we recognize we need to be different. As there is increasing followership in emergency care in PNG and across the region, what we really need now is a foundational doctrine of how we deliver emergency care, a core set of values, beliefs, resources, and systems that can underpin the way we approach building emergency care systems and delivering this essential healthcare going forward. We have an opportunity now with projects that are happening in the region to use this as a platform for addressing cross-cutting issues across the region in terms of capacity building and systems building in emergency and critical care. If we have a common doctrine, we can collectively ensure that what we are aiming to deliver is high quality, consistent, equitable, cost-effective, and most importantly, sustainable models of care that really can be the foundation of how we continue to grow these essential services in the region. I'm not sure if I'm allowed to mention RECSI, but I think this is a potential platform where both emergency and critical care can work together to find appropriate solutions to cross-cutting issues, and in doing so, remove some of the systemic inefficiencies in the way that we deliver care, capacity building, and systems building across the Pacific. Thank you very much.
Thank you very much, Arabella. We were under embargo for so long with RECSI that we've been well trained to be silent, but I think we have come out with RECSI, so that's great. It'll be a feature as we go on, some more details. So this is part one. That was the overview around emergency and critical care across the globe. And now some vignettes, some case studies for part two, collaborative development case studies. Case study one will be establishing priorities for regional emergency care development. And to talk to that, I'm very pleased to welcome Dr. Georgina Phillips, emergency physician from St Vincent's in Melbourne and PhD scholar at Monash University. Not for much longer.
Terrific. Thanks, Jared. Good morning, everybody. This is a fabulous turnout. I'm not a morning person at all, so I really admire all of you for joining us this morning. It's my pleasure to give a very 3-minute brief snapshot of a very large collaborative partnership project that was done over 2018 and 2019 to establish the status of emergency care across the entire Pacific region. That's all of the Pacific Island countries and territories, Papua New Guinea and Timor Leste, as an example of partnerships, collaboration and consensus. So this was a multi-phase consensus project that involves surveys and in-person face-to-face meetings to establish the status, priorities and standards for emergency care across the whole region. It involved more than 200 Pacific multidisciplinary emergency care stakeholders. It involved 17 different Pacific Island countries and territories. And we used the WHO framework that Jared has introduced with the health system building blocks as our framework for assessing the status, priorities and standards. That publication came out in 2020 in The Lancet. And as an example of the first component of that, which was the status, I just want to show the map that we created of the triage systems that at that time were in use across the whole region. And somebody asked me, oh, what does the map look like? And I said, well, it looks a bit like a dog's breakfast. Just as an illustration of how many different triage systems, each different colour represents a different system. You can see that there's the Australasian, a modified Australasian triage system, the South African triage system, the Solomon Islands triage scale, which is the most exciting one, of course, and in some places absent triage systems. And some countries were reporting that they were using 3 or 4 different types of triage systems. So we were able to get that snapshot of what's happening across the entire region. And then through the multi-phase consensus process, we then worked to establish, well, what standards, according to each building block, and what priorities should there be for emergency care development across the region. And I just want to highlight 4 of the building blocks and some of the priorities and standards that the group of all of those clinicians across all of those different 17 Pacific Island countries and territories came to. In the end, we established 24 facility-based standards, and in the domain, the building block of workforce capacity and training was obviously one of the key priorities, was the number one priority actually. Trained professional providers for some core emergency tasks, and in the pre-hospital space, training for dispatch, lay responders and care provision. Under the systems and processes building block, triage came out and guidelines came out as some important standards to meet and priorities, and in the pre-hospital space, communication and handover procedures. Data and research, a much unloved building block. It was rated as the lowest priority across the region, but as we know, and as we've been hearing all day yesterday, if you don't know what you're doing and you can't measure it, then you can't progress. So there was definitely appetite for building some data systems to be able to register and track patients and measure what's happening. And the important building block of leadership and governance also we developed some standards and priorities for, and again, that was really focusing on clinical leadership, leadership support, leadership training, and in the pre-hospital space, having some medical directorship and medical and some legal protections. That's just a little snapshot. The building block that's not mentioned and it's not covered in RECSI is environment and equipment and medicines, because RECSI is not funded to build things, which is great. It's really much more focused on workforce and leadership and governance, these sorts of building block components. But what that case study, that big project has done, has given us an entire roadmap for development for emergency care across the entire region, and it's given us a framework and indicators for monitoring progress and for measuring how we're going in a terrific partnership with the Pacific community, who initiated this whole project in the first place, and our other collaborative stakeholders and partners and colleagues and friends across the region. So that's it from me.
Thanks very much, Georgina. I'd now like to hand over to Dr. Rob Mitchell. Amongst his many roles that we'll hear about a little bit later, Rob is an emergency physician at Alfred Health. He's also the chair of the Global Emergency Care Committee at the Australasian College for Emergency Medicine. And Rob will be speaking to case study number 2, implementing and evaluating WHO triage tools. Thanks, Rob.
Thank you kindly, Gerard, and thank you to you all for joining us so early in the morning. It's wonderful to see so many here, and particularly like to acknowledge colleagues from across the Pacific region, from Papua New Guinea, from Fiji and elsewhere. It is really wonderful to have your presence and your voices in this room. Georgina has really set the stage for this brief case study about improving triage capacity across the Pacific region, as highlighted in that foundational work that was conducted by SBC, Monash and other partners in 2018 and 19. It established that there is a really strong desire for a consistent approach to triage and for an application of tools that are well suited to resource-limited contexts. And so what I'm going to present is a brief case study about taking a tool that's been developed for global application, developed and promulgated primarily by WHO, but applied and validated in a local context. And it's been really wonderful to be on this journey with particularly Papua New Guinean colleagues over the last 4 years. Many of you will recognise that in resource-limited settings, but in fact in all emergency care settings across the globe, the demand for emergency care often exceeds the available capacity. So it's essential that there are systems in place to identify and prioritise patients with urgent care needs. And this was particularly evident during surges associated with the COVID-19 pandemic. So in recognition of this challenge, a few years ago, the World Health Organization, the International Committee of the Red Cross and Médecins Sans Frontières came together to develop a simple and efficient approach to triage. And the result was the Interagency Integrated Triage Tool. It's got a very cumbersome name, but it's quite simple to apply. It's a 3-tier colour-coded strategy that is designed to be implemented with minimal training at all sorts of healthcare facilities, but particularly emergency care settings across the globe. And this was first distributed by the WHO as part of the COVID-19 response toolkit that WHO released in early 2020. Prior to the release of the tool, we'd established a partnership with WHO to field test it. There hadn't been an opportunity to do that in a robust and rigorous way, and so we were absolutely delighted to, as a group of Australian and Papua New Guinean clinician researchers, to be able to work together with WHO to pilot the tool at a hospital in Port Moresby, Gerrhu General Hospital, and then validate it at a regional facility in Papua New Guinea in Mount Hagen Provincial Hospital. And then during the COVID-19 pandemic, when there was huge demand for these sorts of tools, to work with local colleagues to distribute it more globally across Papua New Guinea and in fact the Pacific region. And so in the context of COVID-19, that tool was able to be implemented in several PNG hospitals, particularly Angao Memorial Provincial Hospital and Port Moresby General Hospital, and its use was validated in a broader population, but also in a population of patients with severe and critical COVID-19. And on the back of that very positive experience, the tool's been is highly valued, our research suggests, by Papua New Guinean clinicians, and we've been able to verify that it is safe, efficient and effective. With the support of the Australian Government through the PNG-Oz partnership, we were able to conduct a training of trainees activity in Port Moresby at the end of last year, which is a really, really wonderful opportunity to bring together clinicians from across the whole country to meet in Port Moresby and ensure that they have the skills and capabilities to be able to roll out the tool across the country. A large number of collaborators involved in this project. It's been a really enriching journey for all of us and hopefully illustrates how you can take a global tool and ensure that it is safe and efficient in the context of a Pacific Island country. And I'd particularly like to acknowledge all Papua New Guinean collaborators who've been sharing this journey with us over the last few years. Thank you very much.
Thank you, Rob. And now I'd like to introduce Andy Macy. Andy's Clinical Coordinator, Global Intensive Care Initiative, the Australian New Zealand Intensive Care Society, and a current PhD scholar at Monash University. And Andy will be speaking to case study number 3 of 4, but this is number 3, Assessing and Enhancing Critical Care Capacity in Papua New Guinea. Thanks, Andy.
Thanks, Jared. It's really a pleasure to be here and to be able to talk today. Rather than an individual case study, I'm going to try and pull together some data from a collaborative research project between Monash School of Public Health with co-investigators at Port Moresby General Hospital and collaborators across several provinces within Papua New Guinea, particularly Morro Bay Province and Milne Bay Province. I'm going to try and pull just 3 topics and 3 opportunities for support from those projects. The first, I'll just briefly point to the literature and identify that there is actually no literature specific to crit care capacity and crit care delivery in Papua New Guinea. And that's somewhat consistent across the Pacific region more broadly. There is some literature across the Pacific, but not a great deal. This is nursing literature, but it also extends to medical literature. Certainly, if you compare to, say, the sub-Saharan African and South Asian context, there's not a great deal of literature in the Pacific region. And I think that's probably the first opportunity and need. It's quite difficult to plan forwards for capacity development if there's not a clear understanding of current service delivery, whether that be around resourcing, capacity, or even epidemiology. Which brings me to the second opportunity that I would like to talk to, and that is understanding epidemiology. So with our collaborators in Papua New Guinea, we're in the process of looking at 3 months' worth of admissions data across 3 hospitals in 2023 in PNG. And rather than speak to the epidemiology itself, something that's become apparent from our data collectors in our conversations is that there are some useful data that either aren't being collected or are being missed on occasion. Some examples would be observations on admission, therapeutic interventions during admission, and discharge diagnosis. And I guess that has a couple of effects. One, it makes it difficult to apply severity scores and prognostication. But from the context of this talk, not understanding the burden of work on a health service, that's something that's quite important for being able to then move forward and look at capacity development initiatives. And something I'd like to mention both about the literature and the epidemiology, there is great appetite in our conversations informally as part of the ANZIC's GICI work during clinical support programs at Angao Memorial Hospital and also through the work we're doing with the research. It's stated frequently that increasing research capacity is really important for Papua New Guinean clinicians. And so I think that's an opportunity for support that would fill this gap and also then build capacity in that research space. And the last topic I'll just briefly touch on is around training itself. And so this is pulled from qualitative data from informal conversations during the ANZIC's work, but also from a national needs analysis survey and a series of 31 interviews with ICU nurses across Papua New Guinea. And there's a perception that there's insufficient access to specialist training within PNG. And there's also a perception that maybe the current curriculum no longer meets the requirements of ICU nursing in PNG. And a couple of reasons given for that. One, there just isn't enough allocation of places at the university level to meet the increasing demand for ICU nurses across the country. It's quite difficult, especially for provincial health services, to release staff for a year to move to Port Moresby in order to complete that training because they're experiencing their own human resource limitations in the first place. So maybe one nurse every 2 years is able to go. And that, with the increasing bed stay, that's just not enough to fill that staffing gap. As far as the curriculum, it's probably actually a positive. Over the last several years, there's been increasing access to critical care specific technologies. There's been an increasing option for therapeutic interventions within Papua New Guinea, and the nursing role particularly has expanded, the scope of practice has expanded, and there's a feeling that maybe the curriculum hasn't grown with that developing profession. And so I think there's an opportunity there as well to support curriculum development, to support faculty development, and to maybe find some strategies to increase through flow into specialist training to meet that increasing demand in the region. That's me, thank you.
Thanks very much, Andy. Now I'd like to pass to Libby White. Libby is a clinical support nurse at Alfred Health, amongst many other roles over a long period of time, and has worked in the region. Libby will speak to case study number 4, which is developing emergency and critical care nursing capacity through peer mentoring. Thanks, Libby.
Thanks, Jared. Good morning, everybody. My name's Libby. I'm a critical care registered nurse with a special interest in global emergency care capacity development and support, especially in nursing. I really love exchanging knowledge and learning new ideas every day, and this has been really brought to life for me through peer mentoring. I've worked in several different countries and most recently completed an emergency nurse education position in Vanuatu in 2021 at Vila Central Hospital. Working in various emergency departments prior to this has demonstrated to me that by working alongside nurses and learning from each other has multiple benefits. I learned about hospital processes, flow and structure from the local nurses, as well as the culture around healthcare, the reputation of the hospital, and how the community viewed the emergency department. The local nurses mentored me about the available resources and the common disease processes, and also how the determinants of health impacted on these. By working alongside the nurses caring for patients, I could role model the standard of care that I provided and support the nurses to fill the gap between theory and practice. I found that nurses often have a really solid theory base of the pathophysiology, but often there's no one available to link that theory with the practical application in the clinical setting. This is where mentoring has been so beneficial. By supporting the nurses to provide clinical care, I could discuss the underlying pathophysiology and help them link that theory with practice. We could understand together why we were providing the specific care and hopefully set up a light bulb moment. Another beneficial feature of this role is that an ICU nurse educator was in Vanuatu at the same time as me. So we were able to collaborate and understand the enablers and barriers to the progression of care for patients. We ran teaching sessions for nurses in both departments so that they were receiving the same information and they could develop together. We ran sessions that nurses from both departments attended, like non-invasive ventilation, so the nurses could understand what the pressures were, both in centimetres of water and also within each other's departments. We shared patient examples and asked the nurses to share their ideas and solutions of how they cared for these patients, especially when conditions were challenging. We hoped that this would build up relationships between departments because, as we have all seen, this makes patient care much more effective when teams are working together towards a common goal of improved patient outcomes. The most important takeaway from the mentoring situations I've been involved in is to build relationships, and I know everyone in this room appreciates how important that is, especially in communities that are really socially cohesive. I tried to be a yes person, responding positively when nurses asked for support, and it took some time to build up the trust so that nurses would feel comfortable to ask questions freely. I tried to build relationships with hospital leaders, university academics, and the Director of Nursing at the Ministry of Health so I could understand the enablers and challenges within the nursing system at all levels and to understand what they believed my focus should be. I also said yes to attending staff functions, social activities, and visiting with colleagues to help build up those relationships. Through trusting relationships and peer mentoring, emergency and critical care nursing can develop in a really positive way, improving patient outcomes. And at Vela Central Hospital, the nurses saw how effective this was and introduced the position of an emergency nurse educator, which was awarded to one of the local senior nurses so he could continue peer mentoring. A total win. Thanks very much.
Thanks very much, Libby. Now we'll move on to the third and final part of the session, the structured part, and that's part 3, strengthening regional acute care capacity through partnerships. And that'll be Dr. Steve McLaughlin and Dr. Rob Mitchell, who are the interim program leads for the Regional Emergency and Critical Care System Strengthening Initiative. They'll speak to the topic, firstly, of introducing the Regional Emergency and Critical Care System Strengthening Initiative, RECSI. Thank you.
Hi everyone again. I'm going to go first because Rob is much better at this stuff, so I will pass over to him to do the initial and sort of introduction of this program. But I guess I just wanted to say how excited we were. So as we've all talked about, patients want not siloed care. They want care that goes through pre-hospital emergency critical care. Obviously we have expertise, people in this room, in a certain area, so that's what we're going to focus on, the critically ill and emergency care patients. But we realised pretty early on that a lot of people were doing work in this space. We were very fortunate to have relationships with colleagues in the Pacific, and when we spoke to them about would it be helpful for us to combine our programs a little bit, to collaborate more, it was a universal and very loud yes, that would be great, rather than disjointed, and which is what we're trying to do in a hospital. We're trying to be collaborative. And then I just wanted to also say, you can see the partners that we've got, the formal partners in this project, and there's other partners as well that will come in. I just wanted to say thank you when Rob explains the program moving forward. I mean, this is also pretty remarkable. Even at the Alfred, for ED and ICU to talk to each other is quite remarkable. But no, it is a remarkable thing that we've got all these organisations who went in for a program. At that point it's unfunded, it's just a plan, it's an idea, to come together to try and provide improved care in the region with regional partners as well. It's quite an unusual thing. This doesn't really happen in this sort of environment very often. We might have one or two partners working together, but to have partners from all over Australia and internationally working together who really, and Rob can attest and others, in all the discussions we had, was really about, well, what's the right thing to do? Have we got local partners involved? Are we doing the right program? Was all everybody ever spoke about. So with that background, we were able to come together and start to put together a program that combined emergency and critical care. And then obviously we tried to formalise that into what's a more ongoing project with support of the Australian Government, and I'll let Rob introduce what it is.
Thanks, Steve. So it is really timely to have this opportunity with so many regional colleagues here in Melbourne to introduce this new program, the Regional Emergency and Critical Care System Strengthening Initiative. This program is very much constructed on the principles of collaborative partnership, of localisation and of sustainability. And it has been a really enriching journey to have so many wonderful discussions with colleagues across the region about what local emergency and critical care needs and how, as a group of technical partners, we might be able to work together to collectively address those needs. So this new program is adopting a consortium approach. You can see that there's a large number of organisations involved. That comes with some challenges, obviously, but we think that will be a really unique strength of this particular initiative. We have a health service and coordinating partner in Alfred Health. We have an academic partner in Monash University. We have some technical partners from across Australia, Aotearoa, New Zealand and the broader Pacific region, as well as Timor Leste. They are St John Ambulance Papua New Guinea, represented here today by the amazing Arabella Kolowan, Menzies School of Health Research, as well as Pacific Community. They are our implementing partners for the three streams, and we have technical partners across, particularly from Australia and Aotearoa, New Zealand. So they are the Australasian College for Emergency Medicine, the Australian New Zealand Intensive Care Society and the National Critical Care Trauma Response Centre based in Darwin in the Northern Territory. And we're most grateful that we've been able to progress this initiative with the support of the Australian Government through the Partnerships for a Healthy Region initiative, which Senator Penny Wong spoke about yesterday in her video address. As has been alluded to, this program will have three streams of work concentrating on Timor Leste, on Papua New Guinea, and on the broader Pacific region, using Fiji as a regional hub predominantly to deliver regional-based training activities. And the program's been designed around four thematic areas which build on the health system building blocks, and particularly the emergency care system building blocks that Georgina mentioned in her talk earlier today. So those four building blocks are workforce capacity and training, systems and processes, data and research, and leadership and governance. So using an integrated and cross-cutting strategy to address those four areas, we hope to work collaboratively to build emergency and critical care capacity across the region. We are very keen to hear from individuals and organisations who might be interested in collaborating with this work. It's a great opportunity to meet you here at the World Health Summit Regional Meeting. A particular person you might like to talk to is Melanie Ratton, who's our wonderful program manager, who's sitting down the front, and you'll see on the panel in a moment. So please, we are very keen to make sure this program addresses needs and priorities across the entire region. Let us know if you're interested in contributing. Thank you.
Thank you, Steve and Rob. And finally, it gives me great pleasure to invite Adjunct Professor Lucas Totoka to the lectern. Lucas is the Australian Ambassador for Global Health and will speak to DFAT support for emergency and critical care systems. Thank you, Lucas.
Thank you. I have to commend the intensive emergency critical care, out-of-hospital care community for being probably the only part of academic health that actually stick to time and can deliver like 10 presentations all within time. But which I'm now hoping not to blow out of the water. But because public health is wishy-washy. But no, I'm super pleased to be here today. Thanks for the invite. We timed the announcement of RECSI to coincide so that we could actually talk about it at this breakfast. So thank you for acknowledging that. I know we've been a pain about not making announcements until the minister makes it, but we are particularly excited with this program. For a bit of context, Rob mentioned that this is part of Partnerships for a Healthy Region, which is a $620.4 million 5-year initiative that Minister Wong and Minister Conroy launched last year. What you might not know is that this was part of the Regional Health Partnerships open competitive call for proposals, which had about $160 million to be allocated for about 24 projects in total. And we had about 200 applications with a total budget ask of about $1.2 billion. So this program made it through quite a number of rounds of very competitive fierce competition. But one of the reasons why I think we we saw the value and the strength of this initiative is how partnerships are at the core of it, how locally led initiatives are at the core of it, and how somehow you manage to bring together such areas that, yes, form a continuum, but often are the most entrenched in not working together because of patch protection and this patient should be yours, this patient, get out of my emergency room kind of thing. So it is refreshing and exciting to see this collaboration happening. It's great that you're partnering with SPC, which is a long-standing partner and essential for technical support and systems building in the region. Arabella, as you were talking, Rob was also giving me context on how essentially you ran the response when the pandemic hit in the region. And I was in Moresby recently, and I had the pleasure of going to the St. John's HQ and seeing the operation there, how the accreditation to international standards works, how unlike many other parts of the PNG system that us and other partners support, there is a pipeline for workforce. There is thinking ahead of how we're going to make this sustainable. There is a very clear plan on how to upskill the local workforce and not make a system that is completely dependent on people coming from the outside. And those are the kind of things that we want to see. So also we're trying to sort out the accreditation of the medical oxygen plant in POM so we can actually get on with that, which has taken way longer than we thought. But from our perspective, we're super pleased with RECSI. This is one of the things that have come up of our expansion of our focus to go beyond just surveillance, communicable diseases, and the sort of more traditional health security. Health system strengthening has to happen at all ends. A lot of the traditional donor support has been focused on hospitals. You build infrastructure, you cut a ribbon, looks good. We, a few years ago, started to finally get a bit more into, we actually need to build up primary care. But what connects both ends and what happens inside the box is often left forgotten. So this is a modest contribution from our perspective. We're supporting this program with $5 million of funding initially, but we're really excited to see what you can build given the partnerships that you've already established just to put the proposal together. There's enormous potential, and we take partnerships seriously. We are not just providing a grant or a funding. We want to work with all of you to make sure that this is successful and can go into the future. But thank you very much.
Lucas, don't go too far. Grab a seat, please. You won't be alone. So thanks very much, Lucas. If all speakers would like to come and sit on the panel immediately. And Melanie also, please, as Program Manager for RECSI. So we have some roving mics and some mics for the panel as well. Thanks very much. We have 10 minutes. Please fire away with questions. Is it all as it seems? Do we really like each other? Are we really collaborating? Any questions from the floor, please? Yes, thank you very much, Chet.
Just to be controversial, Chet Williams from the Alfred. There's still a perception globally that Australia is not doing enough in the region. And I think this initiative is very good, but there's a perception that we could be doing so much more for the smaller countries in our region. We are so resource rich and so intellectually strong, and yet it appears that it's always a small amount just being trickled into some of these countries to help them out. Maybe it's a default question, but it's an observation that's been shared with me often.
I can see Libby's rushing to the microphone. Oh, but passing it on. Lucas, first shot.
Okay. What is enough? The need is enormous, and what we can do is never enough. I think there's always a question of what amount is the right amount. So at the moment, Australia spends nearly $5 billion a year in official development assistance. The vast majority of it is across 22 countries in the Pacific and Southeast Asia, and about a fifth of it is in health. So nearly $1 billion a year spent in health overseas. I'm not in a position to comment on what's sufficient and whether it should be more or it should be less. But contextually, I think there's a lot of views in the Australian society of what it should be. And one of the few times that I've been asked a question in this role by the Senate, in my previous one in COVID, I was being grilled every other day, but on this one, when you go to the Foreign Affairs question time things at estimates, you don't get a lot of health questions, but the only questions that I've been asked are why are we spending so much overseas instead of fixing things at home. So it is difficult to keep that balance. So I'm going to move aside from the is it enough or should be more. What it's really important to us is that every dollar that we spend is used in the most efficient way. And the most efficient way is through local partnerships. The most efficient way is to follow what partner governments think it's important to them. And that's why programs like this, we think, are catalyzers also for more funding, because if things work out, and especially things that are tangible and can be explained, philanthropic funding can be attracted, and we've seen that with a lot of the programs that we fund. So I'm not trying to avoid the question, but we consider what we have at the moment is the envelope that we have, and we need to make sure that we make the most out of it. And we think we're backing winners with this one, and we want to keep supporting and finding other winners.
Thanks very much, Lucas. And Steve, a question or comment?
Yeah, I mean, I don't want to sound like I'm sort of defending in the same way, but I think Lucas's point is a good one, but I also think that when you say, Jed, that we're a resource-rich country, we're resource-rich clinicians and health services as well, and we do bugger all. So I think that's the other thing, is that we shouldn't really be waiting for the government necessarily to tell us or to give us money. We have done a lot of stuff, I think, as Australians. I guess my criticism of ourselves would be we do a lot of piecemeal stuff. A lot of people do a lot of good things, but we've never coordinated ourselves very well. And that, I don't know, Arabella, that's the frustration often comes back to us. You sort of, we're a lot of people doing things. So we probably spend a lot of our own, I don't want to say money, but resources on doing stuff, but we haven't coordinated it, done it well, and then we don't get as good value. We're not providing the assistance or partnerships that we could to local partners. So obviously I'll leave clever people to advocate and discuss with government, but I think also one of the things about this program was that we can do it ourselves really a lot of it. Just even coordination would be a big step forward. And I think, as Lucas said in his little speech, the coordination leads to government's more interest, because it's easier to fund a coordinated program than disjointed things. So I guess that would be my perspective, and I guess part of the motivation for this program is to demonstrate a coordinated approach that partners with communities, and then hopefully we can build on that through funding, through philanthropy, through just our own efforts, and which a lot of people do already. So that's just my perspective.
Great question, great responses. Yes, at the back.
Arabella, it's great to see you up there. One of the problems in the Pacific, maybe not so much in Moresby, but in more remote areas of PNG and certainly outside PNG, is getting people to hospital. The ambulance services are just abysmal in some places and really lacking in other places. Is there anything in the investment to improve getting people to hospital faster? It's a bit of an intractable problem, I know, in a lot of places, but is there any work going on in that space?
Thank you for the question. For RECSI specifically, we have included some programs for Papua New Guinea in terms of the improving pre-hospital systems. Obviously, it's a very difficult environment to operate in, and operational costs are quite high in terms of delivering an ambulance service. It would be inappropriate, I think, for us to ask for support in terms of operationalizing an ambulance, but where a program like RECSI can really help is building systems such as education, so we're able to build a workforce, building systems such as clinical governance, so we can ensure that the people that are delivering pre-hospital care are delivering high quality and safe care. And I think that's an area that service that's more developed, such as St. John Ambulance Papua New Guinea, can really lead in the Pacific. We're rebuilding our education at the moment and designing it to take laypersons with a Year 12 education from a first responder level to an EMT level, where they can potentially go through vocational training and become a healthcare worker. And we're hoping to pilot that in Papua New Guinea and then export it across the Pacific, where many of our neighbouring countries have quite similar operating environments.
Thanks very much, Arabella. That's great. Yes?
Hi, my name is Ines Mixonovis. I'm from the Asian Development Bank. Arabella, another question for you, please. Thank you very much. So PNG has gone through a decentralisation in terms of the health sector. We now have the provincial health authorities across PNG, and they were formed so they could really combine that hospital and primary health care service delivery. My question to you is, so where does critical care fit within a PHA, or where do PHAs fit within the delivery of emergency and critical care in PNG? Thank you.
Thank you. Another good question. At the moment, PHAs all have structures which incorporate emergency care and critical care. There are positions for emergency physicians in all of the PHAs. Before I joined the ambulance service, I practiced in rural remote PNG in Hela province as the provincial emergency physician. So there are mechanisms to extend the reach of emergency and critical care within the PHA system. It's just that health resourcing is very difficult. When you have so many competing priorities, it might be something that might, when you have high maternal mortality and things like that, we're all competing for the same small bucket. And it's really about making yourself relevant and advocating for a service that actually does have huge impacts on patient outcomes.
Thanks, Arabella. We have time for one more question.
Just a quick one. Tony Bettini from Rotary Club of Melbourne. We can announce that we've just made a decision to work with St John in PNG in relation to the PNG snakebite partnership, and one of the reasons that we've been able to do that is the quality of the collaboration that's already been set up through the AVRU and others for a number of years, DFAT, Department of Health, CSL, Seqirus. And I agree with you, Lucas, there's tremendous opportunity and will to become philanthropically involved when we can have the outcomes that are achieved with a project like that. So I congratulate Health and DFAT and Arabella and St John, who've just taken over this partnership, and it's fantastic.
So thank you very much. I'd like to thank the speakers. It's a shame, of course, that we can't ask them. Sitting on a panel and not being asked a question can be a little bit unnerving. But there'll be opportunities throughout the day for people to come and see them. They'll be wearing bright coloured tops or hats or something. Please come and talk to them about the program, the initiative, and the collaboration. I'd also would need to take a picture, because it'd be very interesting to do this whenever the program's finished, and to look back and see what we've said we're going to do, how much of that's been achieved, and we can look back and celebrate some things and find that there were challenges and learnings elsewhere. So I think a snapshot in time, this is at the very beginning of this program. To all speakers, I'd like to credit a big thank you, a huge thank you, in addition to Melanie Ratton, and I'd love to ask Melanie what she thinks, having come on board as the program manager, what she thinks of working with all these people that know each other. Rob Mitchell, Steve McLaughlin, and all partners involved in the Regional Emergency and Critical Care System Strengthening Initiative, RECSI. I'd also like to thank Sally Green, Rhiannon Tate and Mariah Cholly for the great support for hosting this event this morning, for the caterers, for the IT, and of course to the Australian Government and its Partnerships for a Healthy Region initiative for supporting RECSI. Go forth and collaborate. Thank you.